the 17th online UK IOG National OG MDT, and hosted this month by Bristol and Bath. I'm Tom Bird. I'm a clinical oncologist in Bristol. Just before I introduce the rest of the panel, I wanted to quickly touch on a couple of other things. This is the first national MDT since the subcommittee structure has been set up for UK IOG. So we now have a subcommittee for the annual meeting, but also other events, including the national MDT. So I'm one of the co-chairs on that with Clarissa Cho's a surgeon in Dorset currently, and Katie Herbert, a medical oncologist in Oxford. We've got pretty good MDT representation, but we're lacking in dietetics and supportive therapy. So if anyone in that department in particular wants to join the subcommittee, then please do get in touch. We've obviously mainly been working on the annual meeting to date, and we're sort of planning similar sort of styles of events as previous at the moment, but we're very open to suggestions and contributions, both from formal and informal feedback. So please do reach out if you have comments or suggestions to make about UK IOG events and webinars. Either email me or use Carly's standard email contact point. Just in terms of the annual meeting, so hopefully lots of you have signed up for this. So that's 4 weeks today. The list, the attendance list for face-to-face is full. So please, if you no longer can attend, please do update that either on the Eventbrite or email Carly, as we can offer up places to others. For those who've got who have, or colleagues who have submitted abstracts, the extended deadline closed yesterday, so we're going to be notifying successful abstract authors in the next couple of days, so they should hear by end of Wednesday. So thanks for your patience with that. In terms of online national MDT, so welcome to anyone who's not been to any of these before. So this is the 17th meeting, I think started in spring 2021. We've opted today for a sort of entirely case-based discussions, but for those who've been to previous ones, they've ranged from being case-based, but also an opportunity for local centres to present sort of areas of interest or case series or sort of areas of research specialised to them. So we are still looking for volunteers. If you've hosted before, you're very welcome to host again, but equally we'd like as much widespread representation as possible, so please do get in touch. There are options to potentially buddy up. We're also happy to provide panel members for centres who can't sort of host an entire one by themselves. We've also got pharmaceutical companies who are keen to sort of tag on symposiums onto end of meetings, so potentially a sort of half MDT in terms of timing would also be great. So anything that you could offer, we'd be very pleased to hear from you. So please do make contact if you can. So today, Bristol and Bath MDT. So we're 2 oncology centres with one tertiary MDT, 2 cities with pretty good relations outside of the rugby field. Delighted to introduce our sort of mini MDT panel today. So alongside myself from Bristol, we have Jenny Wheat, upper GI surgeon, and Paul apparently has just been called to theatre, so has dropped off the call, but hopefully potentially will rejoin later. And then down the road from Bath, we have Dr. Sharath Gangahara, consultant medical oncologist, and Joe Price, who's the lead upper GI CNS there. So welcome to them, and many thanks for volunteering. We're going to make use of Slido for a number of questions in this, so hopefully sort of add to its value. So for those who've not used it, you can get to this on your phone. There's no sort of formal login, so you can use the QR code or go to slido.com on any device, including desktop, and put in the code there, which is hopefully also pasted in the chat, or there's a web link as well. So we've got potentially 3 cases, sort of time permitting. I'm going to kickstart with the first one. So this is a case of a 71-year-old lady, pretty fit and well, with WHO performance status of 0, background of diet-controlled diabetes, hyperparathyroidism, goiter, and hypercholesterolemia. She comes through via GP service on a standard 2-week weight dysphagia referral pathway. She has an OGD in August 2023 showing a 3-centimeter tumor starting at around about 37 centimeter mark, and a week later has a staging CT, which on the local report finds a distal esophageal thickening in keeping with the OGD report, extending to the OGJ, and 2 enlarged lymph nodes, 1 left gastric and 1 going into celiac region, with no evidence of distant metastases. Her histology is reported locally as carcinoma, but mixed features with a predominant neuroendocrine carcinoma with small cell subtype, with a smaller adenocarcinoma component, with very high Ki67 index. So she comes to MDT shortly after. The local histology report is ratified, CT stage T3N1 as per the local report. So stage 3 disease. So the first question for Slido is sort of try and get a feel for what other MDTs or would do next. So really a question about staging this sort of patient or this sort of tumor. So we have option 1 is proceed to urgent chemotherapy and not proceed with any further formal staging. Option 2, PET-CT. Option 3, PET and also EUS. 4, PET, EUS and staging laparoscopy. Or 5, no EUS but proceed with PET-CT and staging laparoscopy. So hopefully people can get the Slido to work. If not, then let me know. But perhaps we'll bring in my panel. So Jenny, as a MDT chair, what's your feeling about sort of staging pathway for this sort of patient?
Yes, so we've had a couple of these more recently than this case as well. And clearly this is a tumour with a poor prognosis, and therefore trying to get to chemotherapy is the priority here. And so more recently we've looked at trying to be a little bit pragmatic about staging rather than being dogmatic and doing everything that we would usually do in the book. So for us, we've looked at PET-CT only for a more recent case, and I think would probably only do the EUS if we had some specific concerns or we knew we could get key information that would change what we were doing. And then the laparoscopy similarly, on a more recent case, we did a stage. We've chosen to do a laparoscopy because we need to put a feeding tube in somebody anyway. So unless there was a particular reason to, this patient's going to, I think that we would look at doing a PET, maybe in the EUS if there's a specific concern.
Okay, so we've got, so yeah, people keep voting if you feel able to or can do. So we've got 27 people have voted. So we've got PET-CT by itself around 60%, PET-CT and EUS 22%, PET-CT and staging laparoscopy 11%, everything PET, EUS and laparoscopy at 7%, but 0% for no further staging and start urgent chemotherapy. So yeah, about approximately 60% agreeing with your initial suggestion, yeah, PET-CT alone. Okay, so that's what she had. So she had PET-CT, which didn't change her staging. And she was seen in the oncology clinic shortly after and consented to cisplatin and etoposide chemotherapy. So another Slido question. So in terms of the overall treatment plan for this sort of patient, what would your general local approach be? So option 1 is induction chemotherapy and then restaging scan, and if responding, then surgery. Option 2, induction chemotherapy, either sort of 2 cycles going straight on to chemoradiation with more, or potentially induction chemotherapy, rescanning, and chemorad, sort of both included in that. Option 3 would be induction chemotherapy and then radical radiotherapy alone, so not giving concurrent chemotherapy. And option 4 would be induction chemotherapy followed by a sort of palliative radiotherapy dose fractionation. So Sharaf, I'll come to you. What's your take on this lady? She's sort of 71, form status 0.
Yeah.
And yeah.
Yeah, I think worldwide it's a slightly variation. There's a bit of variation. I think in UK, most practice, I think would start with induction chemotherapy first to see if they're the chemo responders and they're not going to develop obvious metastatic disease, because 2/3 of these patients, can develop metastatic disease or at presentation in most cases. So, and they're highly proliferating tumors, so we would want to get to chemotherapy first. So our approach has been in the local MDTs to probably start with induction chemotherapy, and then consider, what we call as consolidation radiotherapy, because there is the majority of these patients still relapse. So I think that's where the terminology is slightly varied, whether we call it radical or palliative radiotherapy, because majority of these patients can still relapse despite treatment. So, but we would start with induction chemotherapy, and if they are the chemo responders, then go on to consider the radiotherapy option.
Okay, we've had a comment in the chat saying there should be an option 5, which is give some chemotherapy, repeat a CT, and then or then discuss options at that juncture. Yeah. And I suppose that's not unreasonable. I suppose that this mainly comes around the sort of surgical perspective, isn't it? As in, if you are going to consider surgery, then at what point do you discuss that with the patient? Is that now or later? So the voting is 70% for induction chemotherapy and then definitive chemoradiation, 13% induction chemotherapy, then surgery, 12% induction chemotherapy and then palliative radiotherapy, and 8% induction chemotherapy, then radiotherapy, then radical radiotherapy. So about 2/3 for chemo rad, another 10-15%, another 20% for some sort of radiotherapy alone after induction chemo, and 12% for induction chemo, then surgery. So she says, what's the prognosis, doctor? Is there a chance of cure? So as Sharath has said, I think these are, obviously we all come across patients in these sort of categories where potentially all the documentation in terms of letters or MDT outcomes is saying things like neoadjuvant or radical or curative intent radiotherapy, etc. But there's obviously a very high chance of relapse, and the sort of 5-year survival for this sort of patient is relatively low, perhaps sort of less than 5 to 10% potentially. So I think the discussions around this is a challenge. So you're sort of saying to the patient that everyone may take a different view, but the communication about suggesting that this is curative intent treatment or not is difficult. So I was going to maybe come to you, Joe, but perhaps you could comment on sort of trying to manage patients in these sorts of situations, which is not just in sort of small cell cancers, but in tumours where the sort of radicalness is at a low percentage end.
Absolutely. So yeah, it's quite difficult, isn't it, to support patients in these sort of situations, because when you've got a clear-cut pathway from the beginning of whether it's palliative or curative, you can obviously then manage their pathway better and get the right support mechanisms in place and everything. So with these ones, it's then, when do you then refer to sort of palliative care support early on, or are we waiting to see what sort of response they have first? we're just picking the right time really to make sure they get all the support that they need, but it's then very uncertain in terms of which way we're going with them, isn't it? So it is quite a difficult sort of support mechanisms for the nurse specialist as well, trying to support them and see. I mean, I suppose it's just a matter of seeing what the individual patients are, how they're coping with it, and what support they need if they're happy to sort of go down sort of initial pathway and okay without sort of how to sort of, it's very difficult. But yeah, it's hard when you know that their outcome is not going to isn't possibly going to be good. It's just trying to pick the right time at when to pass on, isn't it, without giving them some hope as well.
Yeah, absolutely. Okay, so this lady, progress is that she has 3 cycles of chemotherapy. She's coping reasonably well. She's got no significant sort of grade 2, 3 toxicities, but she's reasonably fed up with the side effects of it. But she had a CT scan showing good partial response. I suppose our local management for these is generally, you know, to be more of a non-surgical radical radiotherapy type pathway. So we discussed with her about the option of adding radiotherapy in with either cycles 4, 5, or 5 and 6, or offering a sort of sequential option of completing 4 cycles of chemotherapy alone and then continuing with radical radiotherapy. And on balance, she was sort of keen to finish the chemotherapy chemotherapy sooner rather than later, so we opted for the latter. I don't know how many clinical oncologists there are on the call, but for those non-clinical oncologists, this is a snapshot of her radiotherapy planning scans. So the red is the GTV, or its gross tumor volume. So on the left is sort of some of the lower slices of her GTV, and the blue is the sort of CTV, which includes the sort of nodal region in that area. And on the right is the sort of more inferior end of the nodal involvement and nodal region. So next question for the poll is about radiotherapy dose. So obviously small cell cancers, or predominantly small cells, relatively lacking in prospective evidence. So these are radiotherapy alone doses that are from the RCR guidelines for esophagus cancer more generally. So if you feel qualified to answer this, then could get you to vote now. I think for the non-radiotherapists in the audience, so the main thing about these lower tumors is that your stomach is a more radiosensitive organ than perhaps some of the structures in the thorax. So when you have a esophagus cancer higher up and you're giving radiotherapy alone, then the standard doses would be sort of number 1 or 2 potentially. But if you're treating lower down, then there's some concern about these higher doses in terms of stomach toxicity. In lung cancer, it's obviously the most common place for small cell cancers. They would give sort of equivalent of about 66 gray and 33 fractions. In I treat bladder cancer as well, we'd give sort of 55 and 20 or 64 and 32 sort of level for small cells of the bladder. So I suppose pragmatically people give, you know, as much as they can in that organ site. So the voting is, these are smaller numbers of people, obviously, so 15 votes, so 40%, 55 and 20, 25%, 45 grade 52.5, 13%, 20% now, 40 and 15, and 13%, 52.5. So we discussed this in our local peer review. I'd consented to 55 and 20, but we felt that maybe that was a bit hot for stomach. So we dropped her dose to 50 gray and 20 fractions. But yeah, based on the voting, say 40% of people would be happy for the 55 and 20. So I think in short, we sort of lack obviously good evidence on this, and so there's going to be some variation. So progress 2, she completes radiotherapy. She copes with that fine. She has an end of treatment CT scan, which shows ongoing excellent treatment response, the nodes of normal size. She goes on holiday, has a 3-month interval CT scan, but unfortunately a 3-month scan shows 2 new bulky liver metastases, 4 and a bit centimeters in size. Her last chemotherapy cycle completed on the 5th of January. So she has just over a 5-month gap between finishing that and the date of the relapse. So she's back in the oncology clinic, and we've got some voting options for this. So let's assume for the voting that she doesn't want to consider best supportive care at this present time. So what management would you consider? So the options are: do a liver biopsy given the mixed histology at the beginning, re-challenge with platinum etoposide chemotherapy, use a second-line option similar to using small cell lung cancer, use second-line FOLFIRI chemotherapy, or recommend early phase trial referral. And I'll come back to Sharath for some views on this. Firstly, about offering a treatment at all versus choice if you do. You there, Sharath?
Yeah, sorry, Tom.
Sorry.
So we wouldn't do a liver biopsy because, as I said, majority of these patients relapse, and it would be in keeping with systemic relapse of this disease. So it's not uncommon in these types of cancer to be in this situation, unfortunately. So we wouldn't do a liver biopsy unless it's for a molecular tissue or some kind of in the context of a trial. As you say, she's about 5 months, but most of us consider, anything less than 6 months from stopping platinum-based chemotherapy to a re-challenge interval. If it is 6 months or less, we think they may not be partially sensitive. But she's almost there, 5 to 6 months, so it's not unreasonable if somebody wanted to consider. We wouldn't be able to use topotecan because it's only used for lung small cell cancers. And most guidelines, for esophageal or GI tract neuroendocrine carcinomas, I think FOLFIRI treatment is being recommended by some of these. Evidence base is weak. It's all from retrospective series. So the options are FOLFIRI, platinum etoposide re-challenge, or consideration for early phase trial. Again, we have to bear in mind that the early phase, there's a lot of weight. Not sure if there's one imminently open for the option, and these patients can deteriorate quickly. So patients who are keen for treatment with limited expectations, of course, then maybe we would have gone for FOLFIRI. Or equally, platinum etoposide re-challenge would not be unreasonable, is what we feel, because she was almost 5 to 6 months, 5.2 months from a re-challenge.
So there's just a comment in the chat suggesting that perhaps the biopsy could help in determining whether it's the small cell or the asano components that's the greatest factor in the relapse.
Yeah, I think that's certainly the reason for considering it. And I think as the comment makes is, I suppose the form is more likely, and I suppose you have to balance off if the time in your centre to get the biopsy done and reported. But yeah, no, I think that's certainly valid. So the voting was 48% for platinum etoposide re-challenge. This is from 23 people voting, so small numbers again. But liver biopsy 26%, FOLFIRI 13%, CAV or topotecan 9%, and 4% early phase trial referral. So she did have second-line chemotherapy locally, but with an early scan, given sort of limited chance of response. So after 8 weeks, had a scan which showed further disease progression. Best supportive care was discussed with her locally, but the phase trials, the early phase trial unit had been discussed with her before that local chemotherapy, so she was keen to proceed with that. So in our neck of the woods, Cardiff is our nearest centre offering, and Oxford and London also kindly helps out for some patients. So she went to Valindra and took part in the Target study, which essentially is a kind of UK sort of national genomic study to try and kind of move forward personalised medicine in a sort of tumour agnostic way. So this was so she had circulating tumour DNA assessment here, and then on the right, the patients get discussed, I understand, at a national tumour board meeting with the results. So she unfortunately didn't have a clear actionable mutation, and her tumor mutational burden wasn't particularly high, which can be indicating for immunotherapy. So they weren't able to offer any early phase trial option for her. So as of now, she's receiving community palliative care at home, which is around 18 months or so after her initial diagnosis. So that was case 1. So if there's any final comments, can't see anything. So we'll move on to case 2, which Jenny is kind of going to lead on, and I'll drive the slides, Jenny.
Thanks. So this is a slightly more surgically focused case, looking at a post-esophagectomy complication of an aerodigestive fistula, but with a late presentation. So next, please. So the background is of a 59-year-old at the time of diagnosis with a metabolic past medical history of being obese with fatty liver disease, sleep apnea, hypertension, and some mild COPD on some inhalers. And previous mesenteric venous thrombosis of some kind from 2017, for which he was on apixaban. So like many of our patients, he was a retired lorry driver. But otherwise he used to go to the gym, he was a power lifter, and he has some dogs that he walks daily. And he's penicillin allergic. So he was staged with as a CWET type 3 junctional adenocarcinoma via our usual protocol for staging. There was the only non-standard bit was that there was some mild avidity in a lymph node and the upper border of the pancreas, but it was mild and not really matched up on the CT, and therefore it's considered equivocal, and therefore he had the benefit of doubt to proceed with radical treatment. He'd presented with dysphagia and was struggling to maintain his oral intake, so he had a feeding jejunostomy placed. And even that was complicated by a mild pneumonia treated with some oral antibiotics. Next, please. So then he underwent some neoadjuvant treatment. He had flocked chemotherapy over the course of 3 months. And Tom or Sharath, feel free to butt in if you have any comments about any relevant details of this. So he required a bit of a dose reduction in cycle 2 due to some toxicities. He had a short admission for rehydration after his diarrhea, and he had a 2-week delay with fatigue and a chest infection treated with oral antibiotics. Have you got anything to add, Tom or Sharath? No, in which case?
No, I think he was our patient, but I think, so kind of reasonably standard if someone's been admitted with a sort of grade 3 toxicity to defer their treatment and then restart with a dose reduction, and then so that would, but it sounds like he had another chest infection and then carried on. So yes, he had a more prolonged flock pathway, but did complete the 4 cycles, albeit with some dose reductions.
Yeah. So then he underwent an esophagectomy. Between the end of his chemotherapy and his esophagectomy, he needed some time to prehabilitate. We got exercise physiologists on him and got him up to speed a little bit more, and he underwent his surgery in February 2023. It was a hybrid esophagectomy with lap abdomen open, right thoracotomy, and just the surgical details are that his esophagus veins divided with vicral ties and endo-GIA stapler. Thoracic duct was divided at the level of the hiatus and ligated with vicral ties and hemolox. Conduit formation was with staplers and overs sewn, had an Oranger style part mechanical side-to-side anastomosis with endo-GIA blue staples and 3O PDS for completion, and then a second layer of PDS to complete the anastomosis. He had a post-operative stay which was complicated by a pneumonia treated with antibiotics, and initially he had high flow nasal oxygen. He was on CPAP before he had his surgery, and I suspect he had a little bit whilst he was in intensive care, although we tend to try and avoid it. He had a CT which showed the pneumonia and some mediastinal free air at one point, and therefore we proceeded to do an OGD to see whether there was an anastomotic leak, but there was no leak seen. And therefore an NG was placed across the anastomosis down into the conduit, and overall he recovered and had a 20-day inpatient hospital admission. So his histology returned showing a YPT3N0, so 0 out of 26 nodes were involved, and he had a positive resection margin less than 1 millimetre R1. It was an adenocarcinoma, and he'd had a significant response to his neoadjuvant treatment. So then we'll just go on to the next Slido view. And so what would you offer to this patient as any adjuvant treatment? And just this chap, his immunotherapy biomarkers were negative. So that's why that's not been put as an option. Tom, I think you might need to tell me when.
Yeah, that's all right. So we've got 10 votes so far. I suspect, that there might be some range of answers, but so we got 24 votes or so, 22 votes. So adjuvant FLOT chemotherapies, 64%, 60%. Adjuvant chemoradiotherapy, 40%. I suppose we haven't included it as an option both those treatments, but no one's gone for another option, and 4% have said no further treatment. So yeah, about 2/3 adjuvant FLOT, 1/3 adjuvant chemoradiotherapy, and 4% no further treatment, and 0% another option.
And I think that sort of fits with. There's been a bit more evidence, hasn't there, towards using adjuvant FLOT rather than adjuvant chemoradiotherapy, and the effectiveness of that with R1.
Yeah, so I suppose our local practice probably is evolving, but it's historically mainly due to the observation that R1 patients in some of the perioperative chemotherapy studies, do worse than the R0 cohort. We have tended to consider adjuvant chemoradiotherapy for a small number of cases per year, but this is the sort of case that we would consider it for if someone is node negative but CRM positive, then I suppose biological rationale that the risk of local, the risk from the R1 resection is perhaps more relevant than, say, a YPN3 patient who's also R1, who's obviously got a high risk of systemic relapse from the node. Also, yeah. So this is a patient that our MDT would consider for adjuvant chemoradiation, either with 2 cycles of cisplatin and capecitabine, or sometimes weekly carbotaxol. But I appreciate there is, the evidence base probably would be for adjuvant FLOT, and then in terms of if you're following the FLOT4 data.
Lovely. So should we show what we did, which isn't a surprise given what we've just heard? He had adjuvant chemoradiotherapy with 50 gray over 25 fractions. He was planned to have 2 cycles of cisplatin capecitabine, but only had 1 of those due to side effects. So he had his full radiotherapy with just a week-long delay due to fatigue, nausea and anorexia. And so that treatment was completed over April and May 2023. And do you want to make any comments about your?
Yeah, I'd comment here that he really did struggle. Obviously, he struggled a bit with FLOT and had dose reductions and things. I mean, this, and he, it's very unusual for us to delay or to, miss out radiotherapy doses, or, but he did, I think, I can't remember exactly, but he's in about week 4, and he really had proper grade 2 fatigue, and, really didn't want to continue. So the only sort of option was to sort of say, have a whole 4 or 5 days off and the weekend, and then we'll take stock. But he felt better off that, so did restart it. So he did complete the radiotherapy, but unusually had a week's delay, and the second chemo again was omitted due to that. So it was sort of non-specific fatigue rather than any sort of specific things, but sort of not fatigue and nausea, anorexia. Was the main toxicity, which was certainly more exaggerated than we would usually expect to see.
So yeah, so far so good. He's completed his treatment, but then he had an admission a few weeks after his radiotherapy was completed with an aspiration pneumonia, and he had some of the 3 C's that one learns with the neonatal tox of coughing, choking, and cyanosis during feeding. So he was anytime he ate or drank anything, he was coughing and choking. And he was admitted under oncology, I think, Tom, and he had this contrast study showing that he has a bronchoesophageal fistula with bronchograms on the latter 2 far right images. So then what? So then just some further assessment of this. He had a CT scan. You can't actually see the fistula on the CT, whereas we've had some others which are visible, and it's just got considerable consolidation in the right base, and there are a couple of locules of gas outside of the airway and outside of the esophagus in the mediastinum there. And that's an image from the level of the anastomosis. You can just about make out some of the staples just adjacent to the vertebral body there to identify the landmark. So he went on to have an OGD and a bronchoscopy, which showed the aerodigestive fistulation, and there was a pinhole anastomotic leak into the right bronchus intermedius. And his initial management was with an endosponge, because it was a pinhole. We changed that every 3 to 5 days, and we did that about 4 times. Should we have next? But unfortunately, as we were doing that on the last of those endosponge changes, the anastomotic defect was enlarging. So he went on to have, this was now early July, a thoracotomy, but he had a frozen lung and it wasn't possible to access the conduit. Thoracic surgeons were involved in the case, so it was OG and thoracics together, but there were some lung injuries which caused some air leaks, so those had to be managed with sutures, patches, and Pro-Gel to stop the leaks. At that time, as a sort of salvage type attempt to get some control at all, we did an OGD and applied the clips that we had available, which were Viper clips, to try and close the defects. But you almost get this woodiness outside of the mucosa, so it's firm and the tissues weren't really mobile enough to be able to approximate, and thought that they probably wouldn't hold. So we'll move on. So then what do you do next? So we've got a few options there. Any thoughts from anybody?
So we've got less responses. I'm guessing the oncologists won't feel able to comment. So we got 85% endoscopic placement of covered esophageal stent. 8% replace endosponge. Sorry, it's still changing a bit. Okay, so we've got 3/4 now saying change placement of covered esophageal stent, 12% replace endosponge, 6% right pneumonectomy and the disconnection, and 5%, which is probably one person, something else. Sorry, 10%, something else, and 5% no. 5% no further active treatment, palliate. So yeah, we've got 20 people, one person palliate, 2 people do something else, please comment. 2 people replace the endosponge, and the 3/4, 15 people saying endoscopic placement of covered esophageal stent.
The other is in the chat as a muscle flap between the airway and the esophagus. That would mean having to get to the esophagus, which we hadn't been able to do. We hadn't been able to get to the conduit to be able to do. So just some comments on some of these options then. No further active treatment. Well, the literature says that these patients with bronchoesophageal fistulae have a survival of about 3 months. So then it was discussed in theatre at the time about doing a pneumonectomy and taking down the joint. You'd have to take down the OG join at the time of doing the pneumonectomy so you remove the contamination from the airway stump, because otherwise you get a stump blowout. So we considered stenting, but we'd already had a situation where this patient with an endosponge in place, the defect was enlarging. And we know that although you can control a fistula, you can cover a hole with bore halves or something with a covered stent, but it doesn't really control saliva. So it's so you still have to drain the pleural cavity again, which we don't have access to. The problem with esophageal stenting, as somebody's commented in the chat, is that the radial force of the stent risks making the hole bigger. And does anybody have experience with stenting the airway and the anastomose and the GI tract? Yes, and it often doesn't work. So, Tim, don't. We'll get there. Yeah. So overall, it looks like most people would stent. Yeah, double stenting is a nightmare. So what would we do? We hadn't actually. Wasn't consented for the whole shebang of an OG disconnection and pneumonectomy. So we'd replaced the endosponge because that was at least getting him extubated and controlling it at least temporarily, and that gave us the option to regroup and consider option and allow the air leaks to heal. We then moved on and decided the thoracic's view was it wasn't suitable to perform a pneumonectomy. The lung was considered to be frozen, and so he was managed with the endosponge in place, which controlled the leak site, but it didn't heal. So here you go. Here are some options. And looking at your comments, yes, there are a couple of places that advocate for double stenting, but I would be interested to know if there are other places who actually do it. And then looking at the next Slido options, then we sought a second opinion, and these were the options which were put forward, although they were offered as things we might like to do, rather than things that they would offer to do. So should we open this next one?
So you've got 3 responses so far, all saying vac stent. But, Six people voted, so still 80% back stent, but 17 have said other option. Please comment in Teams chat. And nobody for the other, for stent fix or ASD closure device.
Jenny, did we have access to VAC stents back in 20?
I don't think we had it at the time.
I can't remember if we did or not. It was
I think
summer of
we started
23,
using
wasn't it?
last summer. I think we started using it last summer.
Just in relation to that last discussion about stent, I think from memory there wasn't any sort of stricture in the GI side tract to hold a stent, and when we used to use covered stents to treat Boerhaave or anastomotic leaks, we would routinely resort to putting an absorbable suture through the esophagus to hold the stent in place. And the problem in this case was there was no surgical access to the posterior mediastinum through that right thorax without risking an irrevocable lung injury. And our thoracic surgery colleagues, as you've said, advised that would be not survivable in him, they thought.
I think we've got 6 votes towards this second opinion. So I reckon that looks like 5 say VAC stent and 1 said something else.
Yep. So yeah, we got 6 votes. Yeah, as you said, 5 VAC stent and 1 something else.
So we sort of thought a third option was sought. Actually, by this point, the patient had said that they wanted to hear something else, this was offered. So he went to London and had suture closure with the Apollo overstitch device, which is what you mentioned in the chat, Tim. And he had that done in November 2023, and at the last check he was still with us. So just some thoughts. We clearly had some thoughts about this case, and in particular, was this a surgical? Was this a leak that was present at the time of the surgery that either fistulated almost immediately? Was it a pinhole leak which then eroded into an airway? And was there there's a temporal relationship with the end of his radiotherapy, and then a couple of weeks later the onset of his fistula became symptomatic? Is that just the serendipity of timing, and it was there all along, or was it indicated by the radiotherapy? So that's some thoughts about the fistula. And Paul, yes, he did go home with an endospongin before he went to UCLH. And then the other thing is just some thoughts on the management of fistulation. This is clearly a relatively cold case. It's not an acute injury at the time of surgery with a florid fistula formation. This is a sort of indolent course until that presentation in June. And just to consider some of those options and just be able to explore some of those with the wider group.
Thank you, Jenny. Great. Certainly, yeah, a complex case, and certainly, and thanks for everyone's comments in the chat. Looks like there's nothing further being typed or anything. Okay. So we've got one final case, again from our own MDT, and we're grateful for sort of people's comments about this chap as well. So this guy, 70 years old, on the face of it, pretty fit and well in terms of had what he said was unlimited exercise tolerance, but his main comorbidity was that he'd had a acute MI about 18 months previously, which was stented, with a his kind of immediate post-MI echo was affected as there, but currently functioning well. Performance status was 0. Dysphagia presentation at a local OGD. He didn't tolerate the first one, so they did the second under GA and couldn't pass the scope. He had a CT done just before the GA OGD, showing distal esophageal thickening. He had a reasonably with some suspicious periesophageal lymph nodes, and then he had a precarinal lymph node of about 15 millimeters, which was reported locally as suspicious, and his histology was adenocarcinoma. He went on to have PET CT. Actually, so at our MDT, we reviewed the CT, and they sort of agreed with the equivocal carinal lymph node, and the patient also had a left gastric lymph node, which hadn't been commented on the local report. So he had a PET with a very avid primary tumor, SUV max of 87, avid left gastric lymphadenopathy, and then this sort of paratracheal or carinal lymph node, which was seen on CT, was only mildly avid at an SUV max of 3. He had a EUS staging at T3 with a sort of 8 centimeter long primary tumor. Specifically, the EUS couldn't see any pathological lymph nodes above the aortic arch. He actually had a bit of a labile blood pressure, desaturated during the procedure, and he has staging a laparoscopy, which was fine. So his PET. So sorry, this is just a shot of the precarinal lymph node there at 11 o'clock. So sort of mildly avid, but a prominent node on CT. He had CPEX testing, I think partly because of his tolerance of the EUS and previous MI history, which put him at intermediate risk for surgery. So he came to MDT, and the decision was that we stage this of the primary tumor and left gastric lymphadenopathy, but no definite involved lymph nodes elsewhere. And so he was for neoadjuvant chemotherapy, seen in the oncology clinic, consented to FLOC chemotherapy, but got admitted to District General Hospital after cycle 1 with chest pain. The discharge summary from there was brief, but said that the troponins were negative. The ECG had some T-wave inversion, but they didn't have access to his previous, but we did, and that appeared to be old. But the patient himself was convinced that the pain was similar to his previous MI from 18 months previously, and not an indigestion type pain. So the first question for the Slido is, I suppose from the oncology perspective really, or MDT perspective as well, but what management plan would you consider at this juncture? So he's had this history of possible sort of unstable angina, but no sort of objective investigations to declare that. Would you re-challenge, continue with FLOT at cycle 2 with or without dose reduction? Would you drop out the 5FU component and offer some sort of taxane platinum alone doublet? Would you switch neoadjuvant strategy to one of chemoradiation with weekly carbotaxol? Use an alternative ralph-trexeg-containing regimen? Or would you abandon neoadjuvant chemotherapy and restage and ask the surgeons whether they would be happy to operate at this juncture? So I ask Sharath for comments on this.
Yeah, so this is quite a challenging one, isn't it? It looks like he had cardiac comorbidities before. And for the vast majority of cancers, including colon and other sites we treat, we might lose out on an option. It's important to, we may not be able to use fluoropyrimidines if you say, yes, it was a drug-induced coronary vasospasm, which is what we sometimes suspect. So I would, in a couple of cases, after careful discussion with cardiologists and treating their angina or optimizing their anti-angina medications, we have been successful in giving the fluoropyrimidine, especially if it is a neoadjuvant setting, the radical treatment. And it looks like the main issue here was chest pain without any sequelae, such as any real sequelae. Was the main issue was an angina. So if we can manage the angina with anti-anginas, we would carefully consider in a controlled environment whether we can reconsider re-challenge FLOT, which would be our preference. And also looking at whether it's the infusional component that gives rise to the chest pain rather than a bolus, then sometimes you can omit those. Or if you're worried or concerned this is an unstable angina or may lead to sequelae, then probably leaving the 5-FU has been considered. Not sure there was much evidence for changing to cross-style chemoradiotherapy here, especially in a comorbid with all those comorbidities. So maybe I would think about those options first before I change treatment strategy in the MDT.
Okay. So the Slido poll got 16 votes this time. So we're very split. 25% re-challenge FLOT, 25% switch to chemo rad, 20% use raltetrexed as a swap, and 20% restage and straight to surgery, 13% switch to platinum doublet. We got a request for option 6. Wasn't a great surgical candidate at the beginning. CPET falsely reassuring. Potentially could have offered definitive chemo rad as a sort of with equipoise, I suppose, as an alternative to FLOT and surgery. Paul and Jenny, if we bring this to MDT, what's your views about going straight to surgery? Obviously, he's not a definite cardiac event, but he's had another cardiac possible hiccup. I think we'd probably prefer to try and give him some further neoadjuvant treatment, but
yeah, I think Tim's comment is probably right. We as a unit don't use CPET for all patients, and I sometimes feel that it's a test that produces a lot of data that it's very difficult to apply, especially when, if it's intermediate, what does that really mean? If it's high risk, then you already knew that before you did it. It's a really difficult test to use, but he was declaring himself, I think, from the start as not an ideal surgical candidate. And you want to sort of set yourself up for success, I think. If you're going to put someone through the risk of an operation with all the life-altering sort of consequences of that surgery, you want to stack that risk up against some as good a benefit as you can. And I always feel slightly uncomfortable when we get these patients with locally advanced disease for which we have a good evidence base that neoadjuvant treatment, if we can complete it, can provide a survival advantage, and then saying, oh, actually that's not worked because they've not tolerated it, let's do the operation on its own. And I think we would have to have a very guarded prognosis in that scenario. And I'd probably say yes, chemo RT would be the way I would go at MDT.
Okay. Great, thank you. Yes, this guy we did change to neoadjuvant chemo radiation. But I take the point that maybe, obviously we could have had a discussion about should he have definitive chemo rad at this point, because he's looking less likely to continue on a surgical pathway. But we sort of rushed this through as obviously. So in the end, he'd had one cycle of FLOT, and then he completed a neoadjuvant sort of cross 23 fraction chemoradiation course. Coped reasonably well. Did get admitted towards the end with neutropenic fever, and then had another episode of chest pain on the ward. But again, obviously on the ward, no ECG changes, no troponin rise. So again, sort of uncertainty or not definitely cardiac, but the history was suspicious. So the answer to the paratracheal lymph node, no. Sorry, there's a question. Did we cover the paratracheal lymph node? no. I suppose that would have extended his volume because his other nodes were down in his left gastric. So it would potentially be doable, but going from carina to upper abdomen is getting long. So then he had restaging CT, and he had more nodal issues. So the precarinal node, which we looked at before, was no different, but on CT he had this left sort of above the aortic arch node that had gone from sort of less than 5 millimeters to 9 or 10 millimeters in the time period between between staging and post chemo neoadjuvant chemo rad. His primary tumor and left gastric lymph nodes were unchanged, so he had stable disease in the known areas of disease, but an increasing node here, but not meeting size criteria for being definitely malignant, but increasing in time. I'll go back. So Jenny and Paul again, what would our thoughts be at MDT here?
Jenny's not speaking, so I find these really tricky. The whole reason we do repeat CTs is to look for any evidence of progression during treatment, and we do that with the intention that those patients are declaring themselves to have a tumor biology that probably is not surgically curable. And I go back to that sort of previous comment of we're trying to balance the negatives of surgery against as good a positive as we can make it, and we are quite selective, I think, in who we would operate on. So even if we made the decision agnostic of his pre-morbid condition, I would be fairly reluctant, unless this was a super young, super fit patient who wanted everything done. I would have a very guarded prognosis on this. I think this is outside of where we would normally resect nodes, and if it's enlarging, I suspect you would find early recurrence in that nodal basin. I guess the question is, there are plenty of descriptions of surgeons doing superior mediastinal lymphadenopathies and going all the way up to the thoracic inlet. Now, that's not something that we do, or I, in my memory, have ever referred anyone for. But that is something I'd be willing to hear if other people on the call have had experience of that in the UK.
I think, yes, Paul, my addition to what you were saying is keep looking in our MDTs for cases when we could start looking at essentially what is oligometastatic disease, particularly in nodes rather than solid organs, and keep just having in the back of my mind, are we ever going to get to the point of doing that resection? It's obviously going to take quite a paradigm shift to start thinking about doing that thing. And in somebody who already, as you say, this chap already has evidence of, should we call it, cardiac frailty, potentially, that I think this would not be somebody who I would be starting something new on.
Okay.
George had his hand up.
Yeah, go ahead, George.
Yeah, the superior mediastinal lymph nodes is not an oligometastatic disease by TNM classification. This is original lymph nodes. And in the field of resection, if the surgeon is willing to do superior mediastinal lymphadenectomy. So this is original lymph nodes. If we take the fitness aside, because this is, you're the only one who can really make a decision about it. If we take this aside, then a superior mediastinal lymphadenectomy is an approach which some center do that with adenocarcinoma of the esophagus. Just a little comment that if we're going to give cross to people to the local treatment and we don't include the paratracheal lymph nodes, the lymph node will get bigger in size. So this is not unexpected finding to do. And I think it will come down to the practice of the MDT. Locally here, we resect people with the pyramidostinal lymph nodes. I think the tricky question will come if it is supraclavicular lymph nodes. But for a sphericidostinum, our experience, they are okay to be resected, and they get long-term good outcome if it's been done up to the root of the neck.
So I suppose the challenge in this case is, or a few things in there. So the lymph node irradiation, this lymph node is not the one that was sort of questionably involved. That was down at the carina. So if we'd included that, where this particular lymph node is, it would have definitely been higher again than the radiotherapy field. We've then got.
Sorry, can just say, I think you're right. You can't include it because it'll be too long. You're absolutely right, but this will raise a question of what type of systemic chemotherapy you would get. Yeah.
And I mean, this chap, I suppose, has had only one dose of FLOT, so he's kind of this node's potentially progressed, but he's not had a lot of chemotherapy. But there's still some guarding, there's still guard about his biology here, isn't it? So I suppose our MDT question was, at this point, is he still going to go down a radical pathway? Do we need to gather any more evidence that this node is involved or suspicious, apart from the size change? So I think there's a comment in the comment about doing repeat PET. So that's certainly something that could be considered, isn't it? I suppose if it's not avid, you sort of got to decide what you do next. But so we, rightly or wrongly, he went for repeat EUS. So obviously this was after one dose of FLOT and chemo rad, but this node hadn't been irradiated. So the comment from the EUS operator was that the known involved nodes down in the left gastric territory had specific EUS pattern of findings, and this node, as seen on the CT scan, had the same contrast harmonics pattern. They did try to sample the node, but found that it essentially was too small and close to a vessel to achieve. So it wasn't sampled. So it went back to MDT, and I think the feeling was, given the CT interval increase in size and the EUS findings, that we didn't want to offer, or we didn't feel appropriate to offer him an operation. We wouldn't offer this chemo rad, I suppose, because he's not, in theory, had a radical, had a definitive chemo radiation dose to his primary and lymph node. So he ended up having his biomarkers checked, which we didn't. This was back in 2018, so we didn't have access to immunotherapy at that juncture. But he went on to sort of imaging surveillance. Comments in the chat saying, sort of detailed patient assessment, robot, I'm not sure. No, so the question about why are you sampling a left gastric node? No, sorry, this wasn't the left gastric node. They looked at the left gastric node and then went back up and looked at the higher node that we're looking at, and said that it had similar appearances. So they were trying to access the upper node. So he went on to observation. As it's our last case, we finished with a strange plus point that this guy is still in my clinic 6 years later. So he had some interval CT imaging for the first 2 to 3 years, and then decided not to proceed with that. He had an OGD for some dysphagia about 9 months ago, which didn't show any evidence of malignancy. So unusually, and obviously this is anecdote in one case, but in the end, this guy has, against all the odds, done all right and avoided any further treatment. But not that that's a high level of evidence at all. So he's our last case. Any sort of final comments? Thank you very much to the audience and the contributions and the Slido polls. Thank you very much to my Bristol and Bath colleagues for helping out and and the cases. And as said at the beginning, UK IOG are very keen to sort of continue these MDTs. They don't have to particularly follow an exact case format. It can be a combination of cases and talks. So please do reach out if you're keen to host. We can certainly provide some assistance with that, and hopefully see lots of you at the annual meeting in 4 weeks' time. Okay, I think we'll close the meeting there. Thanks to everyone.
Thank you.
Thank you.
Thank you.